Welcome everyone to today's webinar, a discussion on enhanced recovery methods to improve postoperative outcomes. I am Brian Zimmerman with Becker's Hospital Review. We'll begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We are looking forward to hearing your questions. We will also have a series of audience polling questions during today's webinar. When we reach each poll slide, the poll question will pop up automatically on your screen. Our speakers will give a few seconds for you to select an answer from the options on your screen and click Submit. Thank you in advance for your participation. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. And at this time, it is my pleasure to start today's webinar by introducing our presenters. Tina Keller received a diploma in nursing from Centara Norfolk General Hospital School of Nursing in 1994 and her Bachelor of Science in Nursing from Virginia Commonwealth University in 2001. Selecting surgery as her specialty, she went to work at Children's Hospital of the King's Daughters and worked in the operating room as a surgical first assist until 2005. From 2005 to 2015, Tina worked at Mary Washington Healthcare in Fredericksburg, Virginia as an RN first assist and then a specialty coordinator for neurosurgery and orthopedic spine surgery. In 2015, Tina joined Cardinal Health as a senior consultant, clinical operations, specializing in pre-source and perioperative products. I would also like to introduce Dr. Tracy Smith. Tracy has been a registered dietitian for over 30 years with 18 years experience at Abbott Nutrition. Tracy has a bachelor's degree in dietetics from Ohio University, a master's in nutrition from Ohio University, and a PhD in human nutrition from The Ohio State University. Tracy currently serves as the National Clinical Liaison for Abbott Nutrition. And at this time, I'm pleased to turn the floor over to Tina to begin today's presentation.
I'm really excited to talk about this topic of enhanced recovery in healthcare, as it's definitely top of mind to do all we can to take care of our patients in light of what's happening in our country today. I myself became interested in enhanced recovery protocols when I had to have surgery and went to a larger hospital in an adjacent state to where I lived. And while I was being provided my pre-op counseling instruction, the information was different than what I was familiar with and caused all my sacred OR cows to go moo. Could this possibly be right? I get to drink clear liquids and have a carbohydrate drink up to 2 hours before my surgery. I hadn't heard such things before. Shortly after that experience in yet another town away from my small sheltered surgical existence, I had to help my father through his surgical journey. He had never had any surgery in his 75 years of life and had not only a fear of doctors, but he had a fear of becoming addicted to opioids, which led me to discovering opioid anesthesia options. We all want to do best for our patients. We educate them. In the OR, we are their advocate. We position them with care to prevent pressure ulcers and nerve damage. We prep them thoroughly to prevent infection and make sure the surgeon has what they need to do the case. The surgeon wields the scalpel with skill and sets about to complete their task with expertise and knowledge. But is that all? Will the patient miraculously be better? Patients research their condition more than ever now, with some thinking they're more than their doctor because they saw it on the internet. They have become savvy health shoppers as they research their surgeon, looking up their patient reviews, believing they have selected the best. They do the same with hospitals. Is this the best place for my care? But is that all there is to having a great outcome? We recognize that everyone on the call is at a different level of their experience with and understanding of enhanced recovery protocols. Therefore, as this has become a more prevalent topic over the last 5 years, our goal for this call is to discuss the emergence of enhanced recovery protocols, describe key elements of enhanced recovery protocols, discuss clinical benefits of using enhanced recovery protocols, talk through challenges in the implementation of enhanced recovery protocols, and outline strategies to implement enhanced recovery protocols. We are leaving time at the end of this presentation for discussion and Q&A. Now, let's get started with a question. If a surgery is done well, then why are there bad outcomes? This was the question that the Danish surgeon, Heinrich Galet, kept asking himself. He was fascinated with and studied the effects of stressors on the human body. So in the 1990s, he decided to implement multimodal strategies to improve the outcomes of his colorectal surgical patients. He had many different scenarios that had evidence-based outcomes and would add new ones as they worked to improve postoperative results. In 1997, he released his findings, and as one measure of success, he reported that his patients were being discharged 2 days post-op, as opposed to the average of 7 to 10 days at the time in Europe. With the formation of Enhanced Recovery After Surgery, or ERAS Society, which is a nonprofit medical organization, in 2001 came the aim to establish evidence-based protocols as best practice standards in perioperative care. ERAS's mission is to develop perioperative care pathways and improve recovery through research, education, audit, and implementation of evidence-based best practice. The ERAS Society has published a wide range of publications regarding protocols and guidelines for enhanced recovery after surgery. These have expanded to include most major types of surgeries now and some lesser surgeries that include C-sections, total joint surgery, thoracic, cardiovascular, GYN, urology, and the list continues to grow. What exactly are these protocols? Enhanced recovery protocols are designed to help decrease postoperative complications after surgery. More specifically, they are multimodal perioperative care pathways designed to achieve early recovery after surgical procedures by maintaining preoperative organ function and reducing the profound stress response following surgery. In addition to ERAS protocols, you may hear reference to an enhanced recovery program, rapid recovery, or fast-track surgery, and lately you may even hear the term PSH, or perioperative surgical home use, in conjunction with ERAS protocols. There are a lot of studies out there that show adoption of an enhanced recovery program leads to significant improvements in patient satisfaction, outcomes, and reduction in cost of care. Specifically, patients experience faster recovery, shortened hospital stay, and significantly fewer complications, which are attributed to adjustments in preoperative NPO standards, postoperative nutrition, interventions aimed at early mobilization, and careful selection of anesthesia and analgesia medications to reduce opioid usage. Let's take a look at some of the details of enhanced recovery protocols. The key elements of enhanced recovery pathways aim to reduce response to surgical stress, decrease insulin resistance, and maintain anabolic homeostasis to help the patient return to baseline function more quickly. Data suggests that these pathways have produced not only improvements in clinical outcome and quality of care, but also significant cost savings. Large trials reveal an increase in 5-year survival and a decrease in immediate complication rates when strict compliance is maintained with all pathway components. Enhanced recovery protocols put the patient in the center of its perioperative management and recovery team and empowers him or her by increasing motivation to recover quickly and accepting responsibilities in their own management and recovery plan. Patients will know what to expect and be prepared if they are provided the information in a clear message beforehand. Will you have pain? Yes, but we will use many approaches to reduce and help alleviate your pain. They will be ready to get up and move because they have been told that is what will happen. The protocols are divided into 3 phases: preoperative, interoperative, and postoperative. In reality, they begin once a patient is scheduled for surgery and can continue even once the patient is home recovering. Some of the key principles of enhanced recovery preoperative protocols are preoperative counseling, which includes patient and family education, optimizing the health of the patient beforehand with things like smoking and alcohol cessation, exercise, and preoperative nutrition. Minimal preoperative fasting and including a carbohydrate-loading beverage up to 2 hours preoperatively, antibiotic prophylaxis, and thromboembolism prophylaxis. During the intraoperative phase, the goals include utilizing minimally invasive surgical techniques when at all possible, utilizing multimodal analgesia with standardized anesthetic and analgesic regimens like epidurals and non-opioid analgesia. Prescribed directed fluid therapy. It used to be that anesthesia providers would do their own thing. Some would have lines open all the way, while others were more conservative. Getting everyone to practice the same way ensures a standardized approach. Postoperative nausea and vomiting prophylaxis. Antiemetic prophylaxis should be based on pre-op screening of risk factors. It should be administered in all high-risk patients. Intraoperative drains and the use of NG tubes should be avoided as much as possible. And you need to maintain normothermia. The common protocols for the postoperative phase include multimodal pain control with NSAIDs, Tylenol, and epidurals, avoidance of salt and water overload, early mobilization recommended in getting the patient up and moving and performing activities as soon as the same day of surgery, early oral nutrition with a return to a normal diet as early as the same day of surgery, ensuring good handoff communication, and auditing of compliance and outcomes. Now let's look at 3 examples from 3 different size hospitals that have implemented enhanced recovery protocols and publicly shared their results. The first example is an ERAS protocol result from a small hospital near San Francisco with a nursing-led implementation of evidence-based perioperative protocols to enhance post-op recovery that resulted in about $200,000 in savings. They showed decreased post-op pain measurable by a decrease of 58% of opioid usage, a 61% decrease in antiemetic use, and a 13% decrease in length of stay. The next example is from a large IDN out west. They had opioid exposure cut in half from 10.7 average daily morphine equivalents to 5.4. The amount of time that patients reported acceptable pain scores increased from 82% to 86%. They showed that first ambulatory movement from patients went down by 2.7 hours, and the first post-surgical ingestion of solid foods decreased by 11 hours. In the third example, a group of anesthesia providers implemented ERAS protocols in a community hospital in central North Carolina for urology procedures. In the pre-ERAS group, anesthetic was driven by anesthesia provider preference with no standardized analgesia or fluid management protocols. Postoperative pain management relied primarily on IV opioids with inconsistently applied multimodal agents based on provider preference. Ambulation and diet advancement were at the discretion of the surgeon or the availability of nursing staff. In the post-ERAS group, providers followed an agreed clinical pathway that included standardized prehydration and carbohydrate loading, a specialized anesthetic protocol including post-op nausea and vomiting prevention, directed fluid therapy, and opioid-sparing analgesia with tap block, and finally, early and aggressive mobilization and diet advancement. In addition, patients were given specific instructions and information about the ERAS program to give patients a clear set of expectations when arriving for surgery. Their procedure results were robotic prostatectomies, length of stay decreased from 5.4 days to 1.9, and for laparoscopic nephrectomies, the length of stay went from 5.1 to 2.9 days. During the study period, the 90-day readmission rate pre-implementation was 4.8 and it fell to 1%. They also had a decrease in return to the emergency department within 7 days of 6.45% down to 3.88%. Now, I'd like to hear from you. Let's take a quick poll. We'll give it a couple more seconds. Okay, it looks like 40% have not implemented an enhanced recovery protocol. 14% are just getting started and do not have results yet. 26% strongly agree, 14% agree, 2% neutral, 0% disagree, and 2% strongly disagree. As you saw in the hospital implementation results, the impact of optimizing pain management definitely leads to a reduction in opioid use. Pain management is an important aspect of enhanced recovery, as you've now heard, so I want to spend a little more time here. While Europe adopted enhanced recovery protocols rapidly, the United States has really just bought into them within the last 3 to 5 years. Within the U.S., prior trends have been to discharge patients relying upon narcotic and opioid usage for pain control, and the reasons are clear. Pain is the #1 side effect after surgery. Pain is the #1 worry of patients before and after surgery. It results in 40% of the reason patients return to an acute care facility following surgery, and acute pain can lead to chronic pain. Ouch. One thing that stands out in the data of enhanced recovery is the increased focus on reducing the use of opioids, driven heavily by the declared epidemic in the U.S. I want to share a little bit of information about the opioid epidemic in our country. There is no denying the fact that there is a definite problem. In the fall of 2017, the opioid crisis was declared a public health emergency. Data released by the CDC in September of 2017 suggests more than 64,000 people died of a drug overdose in 2016. It surpassed the 58,200 Americans who died in the Vietnam War and 50,682 people who died from HIV/AIDS in 1995. About 3 in 4 of all drug overdoses in the U.S. in 2016 involved an opioid. We probably all remember the cries for Narcan to be on college campuses and increased supplies available to emergency responders. Although most opioid-related deaths are increasingly from heroin and illicitly obtained fentanyl, the crisis is deeply rooted in healthcare. Many people who are currently abusing or addicted to opioids were first introduced and given access to the drug in the healthcare setting. In November of 2017, the CEO of the Cleveland Clinic, Dr. Toby Cosgrove, said, because healthcare providers enabled the opioid epidemic, providers should play a key role in bringing about its end. One of the most sobering statistics from a physician's point of view is that over 75% of opioid and heroin deaths began with a prescription painkiller. The healthcare industry bears some responsibility. That's not to say that patients aren't in legitimate pain. They are, maybe as many as 100 million by some estimates, but healthcare providers have to approach pain differently, smarter. With such a huge crisis, there are many opportunities for anesthesiologists and surgeons to reduce opioid use. One way that has emerged is the use of multimodal analgesia and enhanced recovery after surgery initiatives, which standardize care and improve outcomes while providing satisfactory perioperative pain control. With traditional acute pain management, it has been opioid, add another opioid, and then even add more if necessary. The difference within multimodal approaches, it begins with Tylenol and or NSAIDs, local injections or blocks, and advances to low-dose opioids if required, with the last resort of IV opioids. It's exciting to see progress in the reduction of the use of opioids in our country to help prevent overall well-being. We also know there is an abundant amount of data showing that using nutrition as part of an enhanced recovery protocol also benefits patients, which is slowly gaining traction in the U.S. Before we hear from Tracy on the benefits of nutrition for enhanced recovery, let's take another poll.
So thanks, Tina. the question here is whether or not your organization has adopted nutrition as a key element of improving postoperative patient outcomes. Disagree, agree, or I'm not sure. All right. So the response here is that almost 50% of you have adopted nutrition. That's awesome. 21% have not, and 29% are not sure, and that's perfectly fine to not be sure. You may need to, work with your enhanced recovery teams to find out if nutrition has actually been involved and played a role. So that's great. So, as Tina was talking about the slow traction in the U.S., it may be driven by a number of factors, including, first of all, nutrition is not top of mind and can often be overlooked. Also, the science of nutrition may not fully be understood, and quite frankly, the old habits of NPO before surgery are very hard to change. But with over several decades of data and studies, we know there are multiple benefits of perioperative nutrition. First of all, there are clinical and economic benefits that are important to the C-suite and the administrators in the facility. Improved surgical outcomes and reduced infectious morbidity and mortality. Studies have shown reduced length of stay and decreased cost of care, and also complications and morbidity. Probably more importantly, in the eyes of clinicians, are the patient benefits. First of all, calories provide the large amount of energy needed during the stress of surgery. Surgery is almost like running a marathon in the number of calories that you need in order to get through. Protein, arginine, and omega-3 fatty acids, these are specific nutrients that help to reduce the surgical stress by supporting the immune system. Carb loading, as Tina was pointing out, is very important before surgery to replenish glycogen and energy, and can help reduce insulin resistance. Protein-rich foods and oral supplements before and after surgery help protect muscle from breakdown, which can help to reduce the fatigue, the lethargy that the patient feels, and help them to recover and get up and start moving around more quickly. Tina also mentioned the ERAS Society earlier, and there are multiple subspecialties that have adopted nutritional guidelines, and you can see some of them there. I just want to give everyone the heads up that these can be downloaded free from the ERAS Society's website, erassociety.org. So specific to nutrition, and specifically here with carbohydrate loading, in 1999, the American Society of Anesthesiologists issued guidelines to allow clear liquids up to 2 hours before anesthesia for elective procedures undergoing general or regional local anesthesia. And it's important to know that this came from this society. Often it's the anesthesiologists who resist this change, although it came from their body of literature. But carbohydrate loading has multiple benefits. It reduces postoperative hunger, thirst, and anxiousness, reduced postoperative insulin resistance, and reduced postoperative nausea and vomiting. The outcomes you see on this slide have been done from a global perspective, both U.S. and Europe, and have all utilized carbohydrate loading drinks that contain a complex carbohydrate maltodextrin. This is important because maltodextrin has different properties than simple sugars that can be found in lemonade, fruit juice, or sports drinks. Also, the majority of the studies examined the use of 2 servings of complex carbs the night before surgery and 1 serving of complex carb the morning of surgery 2 hours prior, as Tina had discussed. The outcomes that you see here are based upon the physiological effects of glycogen storage needed for the body to supply energy to cells during the stress of surgery. And it's also important to note that patients do not need to be malnourished to benefit from carbohydrate loading. Everybody can benefit. So as you can see here, the multiple proven outcomes can really lead to enhanced patient experience and satisfaction after surgery. On the next slide, we're going to look at adding the use of immune modulating perioperative nutrition. And we also know that there are multiple dozens and dozens of randomized controlled trials looking to hold up these outcomes. So first of all, we see decreases in length of stay that are related to reduced wound complications, reduced infectious complications, and then also related to that reduced length of stay, we also see reduced hospital costs. Now, immune modulating nutrition is very special. It's different than just a basic oral nutrition supplement that you might find on the shelf at the grocery. These immunomodulating supplements contain arginine and fish oil. And arginine is an amino acid that is needed during times of stress. The body utilizes a large amount of arginine during stress, and a source of it allows the body to heal and fight infection. So the surgical stress just makes body arginine plummet. Fish oil, on the other side of this slide, can help downregulate the stress response to the surgical process, allowing for a less inflamed environment. So the fish oil and arginine are actually synergistic to give patients perioperatively these benefits. They are uniquely designed around the research and are an enhanced recovery guidelines that have been published by professional organizations. And as I said, there are multiple randomized trials, global in nature, and have a very long history of well over 15 years. Over 100+ hospitals in the U.S. are currently providing the Abbott Nutrition surgical bundle of nutrition products to patients who are undergoing a variety of surgeries. And when I say the bundle, that means both the immunonutrition pre and post, and then the carbohydrate loading. So as you look at this slide and you can sort of see the pathway of the nutrition bundle, I'm just going to quickly tell you 3 examples of hospitals that are using products in their pathway. The first is a hospital that's part of a large IDN system based in North Carolina. They incorporated the full nutrition bundle into their colorectal enhanced recovery pathway. However, several principles of enhanced recovery were instituted along with nutrition, but since the implementation, they have seen dramatic decreases in surgical site infections. Surgical site infections reduced from 11.3 down to 2.1%. Length of stay went from 8 to 3 days, and they realized a cost avoidance of over $1 million. So with those great results, they have since expanded into other surgical types and added nutrition also to those enhanced recovery pathways. The second example I have is a heart hospital in Arkansas that decided, based upon the strength of the data, to incorporate this full nutrition bundle that you see on the slide into all of their heart surgeries. They also decided, from a patient experience perspective, to provide and underwrite the product for the patient. So this addition to their enhanced recovery protocol has just started. I don't have any outcomes at this time. However, there is also a plan to expand this nutrition bundle into bariatric surgeries as well. And then lastly, there's a large system, again, this one out of Georgia, that's also widely adopted this nutrition bundle for all surgeries, all service lines, and provides and underwrites the cost for all patients. In this case, pre-admission testing is key to educating patients and providing the information necessary to keep patients compliant. So I just want to say really quickly before I turn it back to Tina that every hospital has a different way of getting products to patients. Two of the examples I shared here, the hospital actually underwrites the cost and gets the product to the patient through delivery to home. Some hospitals sell the product through their pharmacy or their cafeteria to patients, but every hospital has a different way, and Abbott has worked very closely with these systems to help tailor the logistics for the patient so that it eases the burden to the patient. I mean, obviously, surgery is stressful enough. So, as we see here, many systems have had success in implementing nutrition into their enhanced recovery pathways and protocols. Next, Tina is going to discuss some of the challenges and key insights for success. So I'll turn it back to Tina.
Thanks, Tracy. That was really good information. Even though we've provided an overview of enhanced recovery protocols and the successes that some have experienced, there are still many challenges. In my research and based on my experience, there are 4 key challenges of note. The first is lack of internal buy-in. There's a resistance to change, right? We've done it this way. We're going to keep doing it this way. We don't need anything different. They start off strong, but then interest wanes with time, especially if there is partial adoption of protocols. There's a lack of patient and or staff compliance. They don't want to bother with it today. What will skipping one thing do? It's challenging and the process is complex. Partial adoption or silos. An example of this may be that anesthesia implements protocols, but they don't take it outside their practice. Or maybe they get a surgeon to buy in, but then it's not taken outside the surgical arena. Inadequate tracking of successes or data in general. Compliance data, cost savings. How else do you know if the protocols are successful and what changes may be necessary? So with these challenges in mind, how do you work to combat them? The first critical step we've identified as key in successfully implementing an enhanced recovery protocol is collaboration. We must first begin with collaboration as being clear on the desired outcome of the program. This includes identifying the key stakeholders and champions, including a nutrition champion, which doesn't have to be a registered dietitian. It could even be the surgeon himself. Decision makers, and being clear on the needed investment for success. All of these things help support the path to internal buy-in, reducing silos, and driving staff and patient compliance. A big part of collaboration, as many of you know, is establishing a framework for clear lines of communication throughout the planning and execution of the process. This will support a consistent patient experience across the board and enable an empowered path to recovery. Next is coordination. Many hospitals begin implementation with one service line and based on results expand into others. As part of coordinating across and into many multiple service lines, communicating along the journey, the protocol pathway from the pre-op meeting to the follow-up calls or visits after discharge can aid in driving best practice sharing and reducing the learning curve. There have been instances in which one department was executing enhanced recovery protocols and counterparts in other departments and cross-functional team members were unaware. In order to drive consistent coordination, many hospitals have hired enhanced recovery coordinators to help connect the dots, including consolidating products, tactics, and communication. Communication is a consistent theme throughout protocol implementation that can either make or break program success. As more hospitals adopt protocols to help deliver improved postoperative outcomes, ensuring there is ongoing education of both staff and patients throughout the program, Execution is key. Further, creating clear methods to examine program progress, including tracking what's working and what's not working, also known as program auditing, can help check and adjust methods to yield optimal results. In order to effectively implement a successful enhanced recovery program, it is encouraged that your organization focus on collaboration, coordination, and communication. Yielding to these three focus areas supports driving staff and patient compliance, which help all parties involved feel supported and satisfied throughout the journey. The potential rewards of reducing postoperative outcomes decrease length of stay and readmission rates, which can yield lower costs as well as increased satisfaction for the patient and providers, is worth the effort. This is what it's all about, optimizing outcomes for our patients. And to do that, it's a combined effort between the patient, the surgeon, hospital staff, hospital leaders, and let's not forget about third-party partners. A third-party partner can help support the protocols you put into place by providing the best product bundle per service line and coordinate how to get the product to the patients, either through the hospital to hand out or directly to the patient's home. Yes, executing enhanced recovery protocols is commitment. It's a commitment to a process that has the potential of expanding as evidence-based practice data increases. This is not just for colorectal surgeries, but is already being leveraged across most major surgeries. Large hospitals and IDNs are not just exploring or executing enhanced recovery protocol, but smaller community hospitals and surgery centers are interested in as well. With all the information patients can gather on their own, will they start asking to have their surgeries at a facility that practices with enhanced recovery protocols? Probably. So as we move into Q&A, we want to leave you with 3 questions to consider as elective surgeries ramp up and what the world is calling our new normal. What more can we do to help patients feel more confident going into surgery? How can we help patients better prepare for their surgeries? And what steps can we take to improve our patients' postoperative outcomes? We want to thank you for your time today.
Thank you, Tina and Dr. Smith, for that fantastic presentation. And we're now going to kick off today's question and answer session. So as a reminder, please submit any questions you have for our presenters by typing them into the Q&A box you see on your dashboard, and we will try to get through as many as we can. So the first question I have here, Tina, I'm going to tee this one up for you. So what recommendations do you have to help get internal buy-in when implementing enhanced recovery protocols?
Sure. The first thing I would say is find your champions. And this isn't just one champion. It's probably multiple champions, right? So you need a surgeon, you need an anesthesia champion, you need a nutrition champion. You probably need a leadership champion and a perioperative staff and floor staff champions. And then this isn't something that you implement overnight. Or even the next week. This is going to require a lot of planning. So be prepared for the long process of planning and meeting with all of the different teams. So.
Great, thank you for tackling that. And I think this next question sort of works well as a follow-up. So what recommendations do you have, Tina, to help remove silos and drive standardization across all departments when implementing enhanced recovery protocols?
Well, I think you definitely need an ERAS coordinator. And a coordinator would be able to oversee the program and make sure everyone is communicated to. They would also be able to do the auditing, which is a pretty important aspect to a program implementation. You want to know what the results are, what's going right, what's going wrong, fixing it. So that would be a necessary thing to have, I think.
Yeah, it seems like really getting the right personnel going, whether it's a coordinator or champions, to just make that communication component work is super important.
Right. Yes.
Excellent. And so, Tracy, I want to get you involved with this next question here. So what would you recommend as a first step for a hospital that's just learning about enhanced recovery protocols? First step to get started.
Well, I think it goes back to evidence and data. and there's a lot of evidence and data around enhanced recovery. And why nutrition has risen to the top, I think, for people to be looking into it is because of the strength of the data around nutrition. And again, I can only really speak to the nutrition literature, but my understanding is that hospitals really look at the data, they dive into it, and they figure out which pathways are really going to give them the most benefits and results and best outcomes for their patients. So I think collection of data is important, and as Tina said, finding your champions, finding people that are going to stay with the process and be committed to it in order to get started. And I would just say also across service lines to that last question, as far as nutrition goes, a lot of times a nutrition expert has been involved in the hospital system that sort of can oversee all of the different, it has visibility to all of the different surgical service lines and gets that nutrition message incorporated across the board. So I just wanted to add that because some hospitals have done that, inserted nutrition into multiple surgery types.
Thank you so much for circling back there, Tracy, and addressing that. The next question I have, I'd like you to tackle as well, Tracy. So, this attendee asks, what do the statistics say about aspiration risk when it comes to drinking 2 hours before surgery?
That's a common question, and that one has also really been answered by the anesthesiologist and is actually in their journal. Early studies were done with either lemonade or fruit juice to look at rate of gastric emptying and really found that there was no significant risk of aspiration with those types of drinks. And so those studies really were looking more at gastric emptying time versus surgical outcomes. So the later data on the complex carbohydrate, maltodextrin carb loading, it has a different slant as far as the carb loading literature. But the early studies were done with aspiration because that was the key, I think, to the recommendation, was making sure that patients were safe and they weren't going to aspirate liquids from the stomach.
Excellent. Thank you for giving us that added clarity there. And we've had just a ton of great questions come in. Really appreciate all this wonderful engagement from our attendees today. And Tracy, I'm going to throw this next question your way as well. So okay. The attendee asks, do you see strong research in carb loading for diabetic patients? What about laboring patients?
So good question. The data and the recommendations have been fairly clear for the type 1 diabetic, meaning that there may be more caution needed if the patient is a type 1 diabetic. As far as the type 2 diabetic, those folks are actually at more risk for hyperglycemia than from the stress of surgery than patients who do not have diabetes. So the studies that have been done have actually shown good results in return of glucose to normal with carbohydrate loading. If anybody is interested on the phone with some of that data, Abbott would be happy to provide it after this call, because there are references that we can provide. I think the other question was about laboring. I unfortunately don't know that literature. I don't know the answer to that for labor. But I can, again, if anyone wants to reach out to us at Abbott or to Becker's, they can get my email address and we can answer that.
Yeah, absolutely. I know we at Becker's would be happy to make that connection there. And And Tina, I'm going to throw this next question your way. So has mobile health technology had an impact with tracking patient RX outcomes once the patient is discharged from the facility? Examples given are medication adherence, access to provider information. You still with us?
Oops, I was on mute. I'm sorry. I'm not really familiar with that aspect to it. Kendra, are you?
Well, I think, again, on behalf of Becker's, we can sort of on the back end here make some connections and, see what, for these audience questions that we can't address right now, perhaps we can address them later. Great.
Okay.
So we'll move to the next question. Then we've got a ton here, so no worries, plenty to work with. The next question I have, Tracy, I'm gonna toss your way. So, are there any peer-reviewed published data utilizing the products described in this nutritional bundle?
Yes, there are. There are multiple studies on immunonutrition, and there are multiple studies on maltodextrin carbohydrate loading. Reference lists are available. I don't have, all I can say is yes. We can certainly provide that literature references and citations if needed.
Perfect. Thank you for that. And we'll do a couple more questions here before I ask for some final thoughts from each of you. So the next question we'll take then is, what exactly is in a quote-unquote shake, and are they purchased or created on site? Tracy, I believe this one is targeted for you.
Sure. They are manufactured, so they are liquid drinks, typically, around 8 ounces per drink. They typically are not available at retail because the market is, smaller than just for a regular oral supplement that you see on the grocery store shelf. So you would either go online and purchase. Amazon, I know, carries products. As I said, sometimes the hospitals will purchase it and then provide it to patients. The pharmacy may have it available in the hospital and the patient can purchase it. So there's a variety of different ways, but they are manufactured and provided in that way, but not typically at retail.
Gotcha. Thanks for offering that clarity to our attendees today. And Tina, I'm going to throw this next question your way. So what suggestions do you have to implement ERAS across a multi-hospital system?
Well, I was talking with an ERAS coordinator just this week who had a multi-hospital system, and the best thing to do is start with one surgeon and one specialty, and from there spread to the other surgeons within that specialty at one hospital and then move to another. And it's really, this is where it's really important to have an ERAS coordinator who can help with those kind of things, because they're the ones that are going to make sure that there's consistent implementation across the board.
Excellent. Again, back to that communication piece. And we will reach out to folks who we weren't able to get to some questions, and we'll engage with you all offline. I want to leave plenty of time here just to get some closing thoughts from Tina and Tracy here. Any final thoughts you'd like to share with our attendees? Tina, you can go first, and then Tracy, you want to close things out?
Yeah, just to remember that we are here to help support your efforts with implementation, not with the protocols themselves. Those come directly from the ERAS Society, but with supporting those protocols. We have multiple products that can go out in these bundled kits to help with that. And then it's really the importance of, having those champions to start with. And I will share with you that the person I was speaking with earlier in the week, she went to one surgeon they picked the best surgeon to implement the program with, and they approached him and he said, "No, I'm not sharing I think the quote was secret sauce." So he didn't want to basically, he was thinking, I have to share what I'm doing to get my good outcomes. So they went to second pick and he agreed to do it. And by the time they implemented and released their results, that first surgeon that they approached was then coming back to them saying, "Hey, wait a minute, I want a piece of this." So hang in there, get your champions, and remember, it's a long process. I think that same hospital, they started meetings and everything with the one surgeon and didn't implement for like 6 months to get everything coordinated before doing that. Once they had one service, the next year they added on 8 additional services. So.
Thank you so much, Tina.
Tracy?
Tracy, you want to?
Yeah.
Go ahead.
So here's what I would say the bottom line is with nutrition. Nutrition, as I said, is often overlooked and is really the most foundational idea that you have in order to heal and recover. Without good nutrition, without the right nutrients, it is very difficult to do well in surgery. And so I hope that if you're listening and you're considering an enhanced recovery protocol, that you think of nutrition, you remember that there is a wealth of data. There are a number of ERAS subspecialties who recommend nutrition perioperatively, and really get involved with nutrition. It's one of the lowest cost, lowest risk ways to improve patient outcomes, to improve patient experience, make them feel good. Nutrition is, again, just a foundation, and we often forget it. It's not the most sexy thing, and it's just forgotten. So I hope that we've impressed upon you today how important that is if you are considering your enhanced recovery protocol. I just want to thank Cardinal Health and Becker's for inviting us from Abbott to be on the phone today. So thank you very much.
Yes, thank you both. Thank you, Tina and Tracy, for that excellent presentation, and thank you to all our attendees for the great engagement today. And I will also want to thank Cardinal Health for sponsoring today's webinar. We'll give you a few minutes back to your day. We hope you enjoy it, and we look forward to having you join us for future webinars.